Good evening and welcome to another session of Fresh Natural Live. It's Monday evening, and as of course, we have another great show for you tonight. We're going to be talking about hospital food, more specifically the unhealthy aspects of hospital food. And I think it's really important for you as an audience to understand this and be aware of it because you may have loved ones who are admitted to the hospital, or you may get admitted to the hospital for whatever reason. You may have a, heaven forbid, a broken bone or have to go to the hospital for some reason. Hopefully most of you are taking care of your health. You're not having to be in the hospital like many of my patients for long periods of time sometimes. But I want you to be aware of hospital foods and their particular effect on your health. And so we're going to get into this in great detail. I'm going to do two parts. Part one, I'm going to share our insights to this. We, in my clinic and our nutrition center, we've done considerable amount of research, and we follow patients very carefully regarding the foods they eat, and we look at the biochemical effects of this food. So I'm going to share some of the science and some clinical examples with you. Some of the presentations I've shared in other talks and other contexts, but I'm going to focus on the effects of food. So sit back, get your pen and pencil ready. We have a great show for you tonight. We're going to get started right now. Okay, so as I said earlier, we're going to talk about unhealthy food in hospitals. People like to throw around the phrase food deserts. Probably some of our biggest food deserts are the hospitals, and we're going to get into some of the details. First, I'm going to invite my friends and colleague on, Dr. Floyd Atkins. Hello, sir. How are you doing? And his partner in crime, Dr. Just fine, just fine. And partner in crime, Dr. Pamela Atkins. Hello, how are you doing, Dr. Atkins?
Hi.
So,
Hi, good evening. Doing great.
So anyway, I know you guys don't hang around the hospitals too much. Some of your patients have come out of the hospital or been in the hospital. So I don't know if they share some of the stories of the food with you, but unfortunately, in my rounds in the hospital, I get to see some of the foods that my patients are eating. And there's little attention paid to the food. And what I want to do is do a quick little discussion on why that should be more the case. I don't know, what are y'all hearing from your patients regarding hospital food, or do you get much information from them on that?
Well, it's been a few years since I've seen hospital food, but of course, it's been burned indelibly on my mind. And when I came out of school, that was before the food got good. So that give me an idea of what I see. As a matter of fact, I had a couple. When I looked at the topic, I had a couple of pictures I want to share with you when you finish your presentation of some hospital food. It's self-explanatory.
Okay. I look forward to that. No, that's great. So anyway, Dr. Pam, you have anything, opening remarks or recollections?
Yeah, I practice outpatient medicine, but at times where I've visited patients and friends in hospital, I am rather horrified with the food, very processed, artificial colors, jello, artificial sweeteners, a lot of GMO foods like corn and grits. We're in the South in Houston, and the southern states, many times you'll see grits. But we know a lot of things from my lecture about it's genetically modified, and that's a concern. A lot of eggs and bacon. It's very difficult for plant-based people or people that need to be taught plant-based diet to eat in the hospital because there's not a lot available and not a lot of live, vibrant produce, green foods, etc. Small amounts of that, and it should be more copious amounts. And we always emphasize organic or grown in a pesticide-free garden. That's not available also.
Yeah, that's, I think you made some great points, because it really makes a difference. And what I want to share with our audience today is precisely how much of a difference it can make. And, I'm going to go through a quick little presentation here for part one. So, the issue of unhealthy hospital foods, does it make a difference in outcomes? I'm not aware of any formal outcome studies. We've got some research that I'll share some with you, and we've got some upcoming research. None of them are designed for outcomes, but most of our patients who are admitted to the hospital have chronic disease, and so we want to say, okay, well, what's the underlying process with chronic disease, or what's chronic disease? In essence, chronic disease condition in which a person has an adverse health condition is expected to last more than a year. Simply that. So, we're familiar with heart disease, cancer, diabetes, chronic lung disease, arthritis. Many times people have, multiple disease, liver disease. Liver disease is one. I should have had it on this list, but it's really the thief in the night, if you will, because if you're on, say, 3 or more medications, regardless of what your liver enzymes are showing, you need to be concerned about your liver, especially on 3 or more, over-the-counter medications or prescription medications that you have to take for some ailment, or I should say, or you're eating a standard American diet. And as Dr. Pam Brewer brought up, lots of GMO foods, preservatives, dyes, all these things, these chemicals that you're putting in your system is going through the body, affecting the liver as well. And in addition to having a direct effect on the liver organ itself, it creates a systemic effect to where we have, different underlying processes. There are 2 processes I want to talk about. You can arguably say there's a third important process, which is the microbiome. And I'll, discuss that on another topic. But the 2 of the 3 major underlying processes, one is inflammation, and I liken that to a biochemical fire. When you consume animal proteins, it triggers inflammation due to certain molecules that are on the animal proteins that the body react to. And inflammation is essentially when you stir up the body's immune system, and it sends out biochemical reactions that then causes an uproar of further autoimmune processes. So people who get sick, let's say you get an infection, whatever the infection may be, whether it's a bacterial infection or COVID, the infection, the body's immune system will take control. It may override the bacteria, virus, whatever, kill it. But then the immune system doesn't turn itself off because it's imbalanced, because you have a lot of oxidative stress. And so it creates lots of inflammation. Speaking of oxidative stress is simply these chemicals. We refer to them as molecules that have unpaired electrons from the scientific aspect of it. But these molecules are unstable, so they bounce around, they destroy cell membranes, DNA, other genetic material. So many of you may be aware of oxidative stress. If you've bitten into an apple, sit it on the counter and watch it turn brown, it's analogous to what's happened to a cell that degenerates and ages over time. So these 2 processes, and the third being the abnormal microbiome, which is affected by what you eat, these 2 processes are in such an underlying, is the undergirding of chronic illness. So inflammation, chronic biochemical fire, chronic destruction and wear and tear on your organs and systems, oxidative stress, toxic molecules floating around, causing chronic wear and tear on your systems and organs. So these things are ongoing. So that's why you get a little bit of high blood pressure, a little bit of arthritis, a little bit of diabetes, a little bit of this, a little bit of that. And we live these things. And what happens is that from time to time, you get some kind of a trigger, whether that triggers an infection or something else, that then will cause a flare-up of inflammation, or a flare-up of the oxidative stress. And then you become acutely ill and have to be admitted to the hospital. So Can healthy food have an effect on chronic illness, and what might that be? So what I want to do is kind of share a couple of clinical examples. Some of these we've discussed in other discussions, and these are particular patients who were chronically ill, who we saw in our office, who were admitted to the hospital, and we brought in, but we also had them on a nutritional detox diet, and we followed their biomarkers on this nutritional detox diet. And so here's some examples. So the first case is a 65-year-old man. Now, this patient, he presented to an emergency room. He had a history of multiple heart attacks. He had 7 stents placed, had recent discharge from the hospital with chest pain, we call it unstable angina. He had heart failure with an ejection fraction of 35 to 40%, normal being about 55%. So he was released from the emergency room because his troponin levels were not at the diagnostic realm of a heart attack, but we're going to show the troponins, the ultra-sensitive troponins that we had obtained in the office. So he had symptoms of chest discomfort, shortness of breath, and mild exertion, known coronary artery disease and angina and heart failure is denoted above. And so what did we do? We made medication adjustments and we did a nutritional intervention. So he wasn't, amenable for being admitted for a heart attack. So we took his troponin level on day 1, and this is picograms per ml. So if we went to the emergency room, they measured nanograms per ml. So this would have been, 0.028 or below the level that they would classify as a heart attack. But it is elevated. We like to get it below 10, and ideally maybe below 5 or 6. But at least below 10. So he was above 10. And if it stays this way chronically, there's increased stress on the heart muscle and can potentiate worsening of his heart failure or other things, arrhythmias or the like. So what we did is we put him on a nutritional detox and we followed him weekly. And so within the first week on the nutritional detox, this is from the 27th of July to the 4th, his troponin level went down drastically, and this is on the detox food. It did bounce around. We made a medication change here. We stopped this glipizide because there's some data showing that glipizide can worsen ischemia. I can't say that stopping glipizide caused it to drop back down, but we did stop the glipizide here. But nevertheless, he bounced around a little bit, but he had a drastic drop and the troponin level stayed down. We like it below this 10 level. And so with just a nutritional intervention and the only medication change with the discontinuation of a medication, we saw that his stress on the heart muscle, indicators of stress on the heart muscle, was drastically reduced just by changing his food alone. This other patient, a 60-year-old man, and we saw him in the office a number of years ago, came in. He was very short of breath. His primary physician had called me and asked me to see him that day. We did. He had a previous hemoglobin A1C of 7.8, so was a known diabetic, was on metformin, fasting blood sugars in the low 200s. These were his vital signs: blood pressure very high, heart rate very high, BMI very high, and the like. And so he also was edematous. He had swelling on his lower extremities and some of his pelvic area. So he was in typical atrial flutter. I'll show you the EKG in a minute. So flutter, that's why his heart rate was so fast. So that flutter is just an abnormal heart rhythm. So the heart's in an abnormal circuit. We did an echocardiogram and some basic tests in the office. And here's his EKG. That shows the typical sawtooth pattern in the inferior leads. That's the typical counterclockwise atrial flutter. So his hospital course during hospitalization and also after, he started out with a low glomerular filtration rate around, just above 20. That's the perfusion or filtration rate of the kidney. The creatinine was above 3. So his kidney function was very low. Filtration rate should be above 60, ideally 90. So he was like less than 1/3 of the lowest level of the filtration rate of the kidney. And when he went to the hospital, we had him on a nutritional detox. We had the food from our nutrition center delivered to him in the form of smoothies and salads and wraps. And throughout the hospital course, his kidney function had improved significantly. The creatinine went down, which is a sign that you're removing toxins such as creatinine from the blood. So we saw very easy creatinine went up. His albumin level was low upon admission, and on the detox regimen, the albumin level went up. Excuse me. Now, after discharge, the patient went home, and he did get off the diet some, and we saw he came back in more edematous, and albumin level dropped. He had eaten some oyster soup and some other types of processed foods and animal protein, which triggered more inflammation. So this was clearly a sign in this patient, the processed foods, animal protein, and the like triggering inflammation. And in his situation, when he became inflamed, his albumin would drop. And because it leaks, when the capillaries become inflamed, the capillary windows open up so that they're large enough for the large albumin molecules to leak out from the inside the blood space to blood vessels to outside the blood vessels. And so that's why when you measure the blood level of albumin, it drops. We got him back on the detox, inflammation subsided, and the albumin level went back up. So in summary, this patient, when we went with the detox during his hospitalization and part of the discharge time, we were able to reduce his medication. And the other thing I alluded to earlier, many people on multiple medications, many of these medications, in fact, most medications that people take prescription over the counter are metabolized by the liver. That's especially the orally consumed medications. And it can have an effect on the liver. So the fact we're able to reduce medication has a positive biological effect on the patient. Correction and control of the heart rate. Now, we did a cardioversion, if I remember correctly, in the hospital, but the nutrition can contribute to probably him staying out in the normal rhythm. It contributes to decreasing inflammation, reduction of leg edema. It also associated improvement of the albumin because the albumin was not leaking, and his overall better well-being in that time. So that was just the effects of the food. Now, oftentimes people need some medical intervention, maybe need a procedure. In this case, he needed a cardioversion, and sometimes patients need other things, but the food has to be optimal and when somebody who's chronically ill. And so with some of the supporting scientific data, we've published the data, we've looked at food. So while the reason we're so confident that it has effect, we've actually shown it in the lab. What are the clinical biochemical effects? We've had 31 patients with hypertension, hyperlipidemia, and elevated blood pressure, or BMI. We put them on the food using a classification system. So we don't just put them on what we call a healthy diet. We look at the nature of the food, how the food's prepared. Is it raw? Is it cooked? Is it steamed? Is it warmed at a certain temperature? These things are all important, and we documented the precision level of the food in the classification system because you can replicate this. So these are the types of foods they consume, total fruits, avocados, and things, and certain types of things like white potatoes were reduced by 100%, fried potatoes by 80%, grains and so on. Refined animal protein was reduced by a large amount, red meat, all of these things were reduced by high percentage amounts. And so what we saw was a reduction in hemoglobin A1C, a reduction in C-reactive protein. That was about a 30% reduction. That's inflammation. We saw the blood pressure go down. Systolic and diastolic blood pressure went down significantly. Total cholesterol and LDL cholesterol were all reduced very significantly. We also saw, as I pointed out earlier, with the one patient we saw in this population of patient, we saw a 40% reduction in medication, which is important because the fewer medications you're taking, the less of a strain on your liver and other organ systems, because medication can have side effects. What are the effects on inflammation and other atherogenic molecules? Well, lipoprotein A, we were the first in medical literature to show a reduction in lipoprotein A using diet. There was a 16% reduction. This is all in just 4 weeks, by the way. All these changes I'm showing you happened in 4 weeks, and many of them happen within a week. So if somebody's hospitalized for a few days and on a nutritionally excellent diet, you're really seeing changes within days to weeks. And so it can have an impact in just a few days of being in the hospital. And so total cholesterol and inflammatory markers are really key. Now, of course, their weight went down by 6%. LP(a) went down by 16%, as I pointed out. Total cholesterol went down. But the inflammatory markers, C-reactive protein, 30% reduction. Inflammation, as I said, is a key component of chronic illness and a key component of flare-ups of chronic illness. IL-6 is a cytokine. Again, one of these molecules that trigger more inflammation is reduced by 23%. Many of you are familiar with cytokines. You may have heard on the news of people going into cytokine storms or they get COVID infection. So the food helped reduce all of these things. And cytokine storms are not unique to COVID. They're related to any chronic illness. So most patients who are acutely ill in the hospital are having some kind of a cytokine storm. It could be local to the heart, or local to the kidney, or local to the liver. Or it could be systemic if they're systemically ill. And so this acute inflammation with cytokine storms of sorts can be widely prevalent. Total white blood count goes down, another sign of reduction in inflammation. So we're actually in the process of launching a new study within days or weeks of recruiting. We're going to look at some of the clinical and biochemical effects of the defined plant-based diet and cardiovascular disease. So we're going to recruit patients with known heart disease, and we will be looking at that. And here's some of the things we're going to look at. And I'm not going to bore you with all the details, but I thought for those of you who have a clinical background or know people who have clinical background, this would be helpful to you. So we're going to evaluate, again, as I said, the relative clinical and biochemical effects of the defined plant-based diet, and we're going to compare it to the Mediterranean diet. The Mediterranean diet is a relatively healthy diet. It has some definitions to it, but we think that it doesn't go far enough. In fact, we know that it doesn't go far enough. We're going to show the mechanisms as to why it doesn't go far enough, especially for acutely ill patients. It's going to be a randomized controlled study of individuals with a known history of coronary artery disease. We'll document that based on EKGs and historical reports. And the study is going to correlate with clinical effects of the diet with biochemical and molecular change. This is really probably the most exciting part of these bullet points because, oftentimes, it's the previous study, and we did some detailed correlations there, but oftentimes you'll see someone present data saying, well, we did this and we saw blood pressure go down, or we did this and we saw these biomarkers go down. But we're collaborating with Georgia State University, and we will be looking at the biochemical effects. What's changing in the genomes. We're going to look at the blood and see the blood's effect before and after the nutritional intervention, the blood's effect on human heart cells, the blood's effects on human endothelial cells. We can look at the genetic effects and epigenetic effects, and we're going to correlate these biochemical changes with the clinical change. This is rarely, if ever, done in medical science. And so this is something that we have looming. So the measurements, we're going to look at the basic anthropomorphic and anthropometric and also hemodynamic data. We're going to keep a close count on medications. We're going to check echoes, EKG stress tests, continuous telemetry monitoring, look for arrhythmias. That's going to be important. We're going to look at endothelial function, which is important. Blood measures, we're going to use the standard clinical blood measures. This pulse score looks at vascular inflammation, metabolic panels, and the like. They'll be taking a health questionnaire, 24-hour dietary recall will be done. And then the biochemical assessment, TNF alpha, IL-6, IL-1 beta, nitric oxide, antioxidant activity. We're going to look at enzymatic and small molecule. We're going to measure the polyphenol analysis. We're going to do pre and postprandial polyphenol measures, pre and postprandial blood sugar measurements, and also insulin measurements, pre and postprandial. So that's going to be very important. Macro and micronutrient assessments of the food. So we're going to do a biochemical analysis of the foods in both diets. So it's not enough to say, well, we have this diet and that diet, but we're going to say, okay, what are they eating and what's in the food that they're eating, and going to compare the two. Going to look at monocyte leukocyte isolation analysis, very detailed endothelial nitric oxide synthase activity, intracellular. These are all biochemical enzymes that's telling what's happening inside these cells. At the same time, we're looking at the clinical aspect of the patient. At the same time, we're looking at the food. We already have some early indication of what's happening. We're going to get detailed analysis. This is really important. This is what should be done in all aspects of medical science. We're going to look at, as I alluded to earlier, treatment of human cardiomyocytes isolated from the left ventricle. So the lab we're collaborating with, they have these isolated cells. They're going to look at gene expression of hypertrophy. They're going to look at sarcoplasmic reticulum stress. Sarcoplasmic reticulum is the little organelles inside the heart muscle cells that release and take up calcium, and it has effects on the electrical system of the heart. It also has effect on the contraction and relaxation of the heart. And we're going to look at pro-oxidant and antioxidant enzymes. So I apologize for all the technicalities, but the summary of it is this. We're going to have a detailed analysis of precisely what our subjects are eating, and we're going to follow them clinically, and we're going to look at make a detailed assessment of what's happening inside the bodies, inside the cells, and how that correlate with how well they're doing. So we'll be able to have make a scientific analysis of this. And by the way, it's not like we're going to feed them robot food, but this is a little bit of a sample of some of the food that we'll get on the nutritional detox regimen. And some of the, like a better than tuna sandwich, Hulk burger, onion rings. They'll get superfood, food, nut supplements in their smoothies and the like. And so these will be the foods on the defined plant-based, and the Mediterranean diet will get the typical Mediterranean food. But I thought I'd just share that with you to give you some insight as to what we're doing. What I want to do is take a quick break. And when we come back, I want to get comments from my colleagues and also questions from the audience. So we'll be right back. Okay, so we are back. And so again, the point I want to just reemphasize is that we clearly have evidence that food makes a big difference. That's number one. And number two, there's evidence that shows that it's not just any old healthy food. You have to be very precise with what you're preparing and how it's prepared and what it is. And you have to look at the actual effects of the food, because I think based on the clinical examples we have, and I have many other clinical examples I can share with you that we know of and that we've tracked over the years. And so we have clear anecdotal evidence that the food has a big impact on how well you do, in an acute illness inside the hospital or outside the hospital. And we think it's an important thing to look at. And our goal is to help educate the medical community as well as the community abroad and make you aware of this. All right, colleagues, any comments?
So the first patient you had, that patient started in the hospital that you talked?
Yeah, the first patient, he was in. So the very first patient we had the very short abbreviated discussion on, he went to the emergency room and had chest pain, but they ruled him out for a heart attack. And so he really didn't he just had an ER visit for a few hours and was sent home.
Okay. So that one didn't get hospital food. And then.
But he may have gotten some hospital food through, so he may have gotten some ER foods. I can't say one way or the other. But the other folks did not get hospital food. But go ahead.
So how do you accomplish that? How do you accomplish that patients in the hospital that you want to have on your diet or approved diet? How have you worked that out? Because I find that a challenge for being in the hospital.
We have a slightly rigged system. Our wellness and nutrition center is about 4 miles south of the hospital that I practice at. And so typically I'll have patients, their loved ones will go and get the food, take it there. They have a refrigerator. We write an order. Patient consume food from the Montgomery Heart and Wellness Nutrition Center. In some situations, I've actually taken food to the hospital for the patients. And so this weekend I was taking food to the hospital for the patient. So the answer is we have to make special arrangements.
So that's good. I mean, the patients have to be motivated, or the family has to be motivated, because it is an extra expense, but it can make a big difference. I would imagine. I know it would, but it is a extra expense. So
Yeah,
I guess you just gave up for the hospital supplying what you wanted them to have.
well, not totally. I mean, so you're right. Everything you said is correct. The thing with this situation is what we're doing now, as it exists, is not scalable. Not that I understand. So what we're trying to do is we're approaching it from the angle of close clinical observation and implementation and proof of concept. That's one. Then the other thing we're doing is we are doing clinical studies showing the biochemistry and the science behind it. And then we're going to amplify that to a certain extent. Now, so the key is, and there's a lot of talk about, hospitals having healthy food and so on and so forth. And that's all wonderful. But somebody has to look at the science and say, well, what food by definition is healthy? And what we're doing is creating data in the medical literature, and very strong data at that, to say, well, precisely what we have has been shown to be healthy. And this is the mechanism by which it's healthy. And so that's our MO in terms of, let's document what it is from the clinical side. Let's show the science, and let's, to some extent, show the implementation, because you can easily create a meal system, and we're actually putting an app form where the food can be delivered. We actually have a delivery system. We're going to have it in probably the next, who knows, month or two, hopefully sooner than that, where a patient can order our meal plans on an app. So there are a lot of things that we're putting in place from a logistics standpoint that would certainly make it easier to implement. Now, as it goes with the hospital, we may have to do something where the hospital may reimburse the patient or pay the patient and so on and so forth. What I plan to do is create a pilot study and go to my hospital and talk to them about a pilot study with the data showing it and talking to colleagues. So there's a method to the madness. What I'm trying to do is put together the data to substantiate what we're saying. And so when I go and talk to my colleagues and talk to the hospital staff, we're going to go with evidence, not with just hypotheses and warm feelings. But no, great. I mean, what you said is important to point out, because it's an extra expense for the patient. And even now, as we talk to our audience and whoever's watching this live on recording, and you say, well, gosh, what do I do? I'm not going to tell you what to do from the standpoint of a clinical standpoint, but what I will say is that what we found to be most effective in our clinical patient is that they go on a plant-based diet, preferably a raw plant-based diet. And in fact, what we do for our patients when they're going for surgery, we do pre-op clearance. We also put them on a raw detox going into the surgical clearance, whether it's orthopedic surgery or whatever. And we express that it's important because it will decrease inflammation, decrease risk of infection, and the like. And so this is something that we really emphasize with our patients and try to point out. And Dr. Ford,
that's a great point. Oh, okay.
Go ahead.
I think that's a great point. Preparing for a surgery or procedure, et cetera, to decrease inflammation is a great idea. I don't think we always think about that. And maybe in the future, maybe the patients that get their food as you provide, or on the outside, if it is approved, that maybe they could get some type of reimbursement on the food that they're not eating in the hospital. Maybe that, right, as you alluded to, in the future, sometime in the future. I'm excited about your study that you're going forward with, that you should have some great data with that. I did look up a Journal of American College of Cardiology, one discussion about, it was entitled Individual Nutritional Support for Hospitalized Patients with Chronic Heart Failure. And it was May 2021. And I think the data was collected in Switzerland. Interesting. But
I'm sorry, what's that title again? I'm sorry.
It's called Individualized Nutritional Support for Hospitalized Patients with Chronic Heart Failure.
Okay.
And that was May 2021 of the Journal of American College of Cardiology.
Okay. So what did they find?
Well, it was just a discussion, but they had a small group of patients. I think it was like 600 and something, but they gave one group that they ate the hospital food and with no additional counseling, and then the other group had nutritional counseling. I guess the nutrition dietitian at the hospital, and they, I guess, had some guidelines in eating the food. And they said the first group that had no nutritional counseling and hospital food, they said, let me get it right, said, I believe they said a quarter of the patients passed away, died. And then the other group, let me get this straight, they said a third of the patients passed away. But these are very serious patients, admitted with congestive heart failure and chronic congestive heart failure. So these are very, these are very serious patients, and but I believe they said, okay, let me go back to, they said, they had 645 patients, and they said that one group, a quarter of the patients died, and the other group, it was a third of them died. And so I don't know if there was a really a difference with the nutritional counseling, but still we're eating the hospital food.
So both groups are eating hospital food. One had counseling, one did not. Is that the
yeah? From, I guess, the dietitian or nutrition.
And this is the study.
Person.
I'm just bringing it up for our audience to see if y'all want to do a screenshot of that.
Yeah.
And I'll just do I'll probably save that and go through it. That's actually interesting. But so let's examine this real quick. So as you said, 645 patients chronic heart failure with acute decompensation participated.
So I think the ones with no nutritional support, a third of them passing away. And I think with nutritional support, a quarter of them passed away. But this is a serious group of patients that, have, a poor, not always good prognosis with chronic congestive heart failure. I don't know how far along, they were in their, with what extent was their congestive heart failure, but they were hospitalized for that.
So yeah, 30 days out, and you see, let's see, proportion of survivors, control group, 0.8 to 1, if this was considered at 1, but they considered the nutritional group in its 112, control group 91. So just something as simple as nutritional support, meaning just counseling. All they did is counseling, right?
Yes. And so maybe there was some input in deciding their diet, but I think the bottom line is, we would like healthier options in the hospital and patient education on that. I think one of your audience members, Patricia, made a. Can you still hear me?
Yes, I'm listening.
Oh, okay. One of your audience members, Patricia, made a comment and said that in some of these hospital facilities and patient facilities, what they call a diabetic diet or hypertensive diet is not always what it should be.
It's very far from it. No, you're exactly right. And I mean, it's really a problem in terms of, they give it the label, but it's all the same standard, processed foods with animal protein and the like. And it's over processed animal protein. So it's really something that needs to be changed. I see on another, let's see here.
I think I opened up another.
I think you're in.
Close one.
I'll take you out and see. I'm gonna move your ghost from the studio. All right. I removed your ghost from the studio.
Okay. Do you still have a camera?
Yeah, I still have you on there. So, Dr. Floyd, you have some pretty pictures to show us. What do you want to show us?
Well, number one, I just wanted to mention to everybody that the reason we're talking about this is because a hospital traditionally is a place of healing. So you have to have things that will help you heal. You go there for recovery. You go over there to hopefully eat some things that are nutritious that will be able to help you move out of there. And one thing you mentioned that was, I guess, very important to me is that they have all of these different diets that they mention. Let me see. And so I'm not sure whether the difference between a diabetic diet or a cardiovascular diet or diet for poor circulation, they should all really be the same. But I'm going to pull this up on the screen for you just in a second here.
Yeah, it should be the same in terms of healthy, but they're all the same in terms of unhealthy.
Exactly. I'm trying to get my screen up here. Share screen. Share slides. Open.
Oh, wait.
Diane Little called it a sad diet.
I guess you block it.
Now you can go. I stopped sharing screen on my side, so try it now.
Okay.
So I recall a situation when I was riding on a patient of mine. So this patient had multiple hospital admissions, and she was in for heart failure exacerbation. And so I'm rounding the morning, and so I'm going through. And typically, when I see the trays being delivered, I'll just lift the hood and cover and see what they're on, because I try to get them on a plant-based diet, even if it's from the hospital. And so I got there with my team, and the patient was there, and so we the tray was just being delivered. So the guy from the cafeteria just come in. And so I looked up on one of the smaller containers. I saw some sliced tomatoes, and then another small container, some lettuce rather. And then I looked under the larger plate, and then there was a hamburger, meat and patty, and then they had the condiments, and then there was some French fries or something. And I said, well, what's this? That you've got this, there's a heart patient. And so, I asked the guy bringing up the food. He said, no, the dietitians, hospital dietitians order. Let me call them. And so, he got on the phone. I said, well, so what are you doing feeding my heart patient a hamburger? And so she said, well, it's a cardiac burger. I said, a cardiac burger? I said, well, why don't you go ahead and bring him a pack of pulmonary cigarettes, So, I mean, again, it's it's crazy, but anyway, let me let you take over here. Here's your screen here. So
yeah, I hope most of our audience, for me, was they had maybe visited someone in the hospital or had loved ones who've been there before, so they have an idea of what it looks like. But these are just some pictures I pulled off of different hospitals around the country, meals. Some of these are in England, some of these in the United States, but they're basically the same all over the world. And when you look at them, you're trying to see how is what's on the plate that the person is eating is going to help their blood pressure, is going to help their blood sugar, is going to help their cholesterol, or just their overall wellness. Inflammation. We always get back to that point. And so this upper left-hand corner, this diet really, you're drinking the orange juice, which you would think may be good, but juice and the sweetness of the orange juice is just going to be a fire for more inflammation in your body. They do have cooked beans, which appear to be overcooked. They have white potatoes, which is a starch, which is going to convert to sugar in your body. So people who are prone to diabetes, eating white potatoes is not the best. Now, I think this is macaroni and something. I'm not sure what that is, and I know if it was in front of me, I'd hesitate on eating that. And of course, they have bread again, which is another starch that you have in here. And they do have a small salad, 3 tomatoes. So I don't know what level of antioxidants are included in a green salad with nothing else, but that's just an example. The lower right-hand corner is probably more typical of, and it's all starchy plate. They have beans, where they have a bread, which they call a pasty, which is a bread something with potato in it. And then they have potato slices, and then they have baked beans. And I'm sure the baked beans are high in sugar content because, most baked beans are not going to be just no sugar. And again, a juice, bread, and a banana. And I was just kind of impacted about the different meals. This one shows the upper right-hand corner. I mean, it's absolutely nothing green or nothing live on that plate. Everything is basically a starch. White gravy. You got white flour. You got white potatoes. You have white. Everything's chopped up carrots, probably overcooked. You have a pudding, which is supposed to be blueberry. I don't know. And then you have a sweet piece of chocolate cake, which that's inflammation screaming at you also. And the lower left, again, this baked beans seems to be a standard. I guess that's the cheaper option when it comes to having beans at a hospital is to do baked beans because, it's sad to say that they choose the most, the most cost-effective way to form a plate. Now, I don't know, if this is coming close. I don't know if this is white potato, white turkey, or, in college we used to call it wonder meat because you wonder what kind of meat it is on the left. It's white.
Like wonder
broccoli,
food.
the broccoli like it was cooked on Monday and the day is Thursday, and they keep reheating it every day until everybody in the hospital eats it up.
Maybe I would cook nonstop from Monday to Thursday, but anyway.
And I would give them credit.
Container here. The gravy container has been through a microwave.
Yeah, several hundred times. I will give them credit for the salad because at least they put a few sprouts on the salad.
Oh, yeah. I see that.
Which
1, 2, 3, 4, 5.
You count them with 2 hands. But and sprouts are healing energy. That's a foundation of healing. So that's the plate should be full of sprouts and full of dark green leafies, not just the lettuce. The plate on the right. And if you want to heal and you want to heal, it shouldn't be any animal protein like this meat. It's going to be hard to digest on your plate. And then to eat meat like that, you need enzymes to digest that meat. And I'm looking for the enzymes on this plate. The carrots are cooked, so the enzymes are basically destroyed. Potatoes and gravy is not an enzyme food. There's no big salad or anything to produce enzymes to help digest this meal. And then again, that chocolate cake, which is a sugar, and have bread. So you have not only wheat, but again, inflammatory things. And again, it's the same thing wherever you look, you see the same kind of process. So I just want to share those few pictures with you. Oh, I have one other thing that I can share with you also.
Well, that's I mean, that's a picture's worth 1,000 words in the sense that we have. It doesn't look good, and most of it doesn't taste good. Now, imagine you put enough salt on it, you could probably make it, palatable to a certain extent. But it certainly doesn't make you healthy.
Now, can you see our screen now?
Oh, hold on. Yes.
You said it's breakfast. Can you see breakfast?
Now the breakfast.
Wait, let me reshare again. Maybe it's not shared. Let me
Yeah, so the point is that they really need to invest more in healthier food as opposed to just medications. A hospital should be a place where people go on detox. We have a vision at Montgomery Heart and Wellness where we will have centers where people can detox. There are other detox centers. Granted, people who are in the hospital, who are discharged, probably need to go to a detox center and detox from being in the hospital. And this would be an outpatient setting where, they can get optimal nutrition as well as other things. So, let's see. Yeah, there you go. So, quick roasted tomato, feta biscuit.
Yeah.
Okay, much
And
better.
the point of this one is that, and this is a Mayo Clinic, in Minnesota, but they have called it the Mayo diet, and this was the only hospital I placed. This is the good news that they are trying to do a little different. And so I was looking at their menu. It really looks good and fresh. Although again, we can't agree on it because you still need deep food nutrition to identify what's good and what's not good. But they call it it's a breakfast, a roasted tomato with feta bruschetta, but doing things like cheeses and things like that when you're in a healing mode is not necessarily good. Tomatoes, but it is some live food, which we didn't see in most of the films. There's no live food. And then they also show a lunch. This is kind of like breakfast, lunch, and dinner. Italian chicken bread salad. Sounds great, looks great. Again, for healing purposes, adding the chicken in could be a detriment. And then the bread, I don't know why they put the bread in, trying to be filling with it, and they're trying to add more protein. From the nutrition that did this, in all the meals they prepared, they put some kind of animal protein in as a protein source, because they want to say their goal is to have a high and low fat diet, because we've been standing on the premise for so many years that the low fat diet was the way to go. And so, but they're going with the high protein and get fats. And this is another one here. They do have a fish beans, and these really look good. They look nutritious. At least they have some live food in there. All of these could be altered, but they actually have this in one hospital that they prepared. Now, one thing I couldn't clarify, and I searched to find out whether or not this is what they actually serve to the person. This is called the Mayo Clinics in their cafeteria. And I know it's cafeteria open to the public and to the hospital staff, but I don't know what actually goes into the patient rooms or on their trays. I know if you prepared meals like this and gave it to every patient, their hospital bill will probably be another 20% higher, 30% higher. I don't know how it could not be. But I want to share those with you.
It could be. But it certainly looks better. And I think, like you said, to their credit, it's a step. It's probably a step in the right direction. And that's why we're doing the research that we're doing. Because I think the fact is that you need to be precise with the food. We're supposed to be, 21st century, 21st, 22nd, whatever century we're in. But long story short, 21st century medicine, we have to be precise and scientific with what we're doing with our food. And that's why we're looking at the studies, the data that we're looking at, in the way we're looking at it. And right now, the studies have 30 subjects on both arms. We'll get some preliminary data with that. We may extend it to get larger numbers and even look at outcomes to a certain extent. And so we'll certainly look at that, the population and see how they do long term. So that's something that I think is going to be really important to look at and to understand. And we really need to get a handle of this. But what I want to convey to our audience, whether you're listening live or a recording, is that you really should, take a look at, what you're getting in the hospital, not only in the hospital, but also what you're eating on a regular basis. But you become acutely ill, you need to look at changing your diet, change it to something that's much healthy, preferably plant-based. So anyway, before we go off, I want to say, if you're enjoying this material, give us a thumbs up, a like, thumbs up, as I like to say, and subscribe if you hadn't had a chance to. Share this information with a loved one who may benefit from this, who may be in the hospital, may be at risk for going to the hospital. I think this will be very helpful. Any final words, Dr. Pam Atkins?
Yes, quickly, Danielle said that her brother was in the hospital for diabetes and he was served spaghetti with meat sauce. And we know
Yeah, I
the
saw that.
spaghetti is raise the blood sugar and the meat sauce. And Tex Houston said that there's a hospital, Texas Hospital
Saw
Transitional
that.
Facility that had they had available, or they discovered available when they asked for it, vegan, organic,
Organic
they
vegan meals.
said,
Yeah.
meal option, but they did still had to bring smoothies in. So perhaps there's hope there. But
Yeah.
I often have seen with hypertensive cardiovascular patients, eggs, bacon, and grits on the, offered, or any of those combinations offered to cardiovascular patients.
I'm glad you mentioned that because I saw that comment. It did flash on the screen earlier, but Tex Houston 7 makes a great point because it's so they made a special request, and this is one thing you can do. You can make a special request when you're in the hospital. I think if you go out on a limb and make the special request, we'd like to have such and such food. I know the hospital I work at, they will make special accommodations for patients. And so I think as a patient, especially in the hospital for a long period of time, I think if you make a special request, look, I eat this kind of food, et cetera, et cetera. I think many hospitals will go out of the way to do it for you. At the very least, you should try. And to the extent you need to, get loved ones or friends to bring food to you. So you have to take responsibility for your own care because you're the one lying in that bed, and you're the one who's going to have to get out of that bed. So as Tex Houston 7 says, if you don't ask, you don't get it. So give yourself a chance to get it and get the best care. So yeah, you should make special requests in the hospital, but request the right stuff. Don't request your favorite steak dinner or the favorite fast food, fried chicken or whatever, or fast food, hamburgers. Request this, I would recommend raw plant-based nutrition. Find Google on your phone, raw vegan restaurant near me. Say I want this, want this, want this. Just tell them what you want to prepare it. If they can't prepare it, then have them go get it. But insist on those things. Talk to the nutritionist, the dietitian, and say, look, I want to eat this kind of food. I heard on the Fresh Natural Live show that there's scientific evidence say this is going to help me get better. This is what I want to eat. And so empower yourself to do just that. Dr. Ford Atkins, any other comments before we close out?
Well, the only thing I would like to add to it is that you open up, we're talking about chronic disease, and chronic diseases we see comes from the chronically poor food we eat that gets us into the position we're in the hospital. So we can change that narrative where we're eating food that is uplifting us and is healing us rather than food that's causing chronic illness. I think that would go a long ways. As far as the getting the food, you really have to understand, that you have to, be proactive. You have to speak up and choose the food. Voice your opinion about the food. Tell them to call the garden kitchen and send me some food from there. But they have to get it. They have to ask for it. Because it's if you don't ask for it, like I said, if you don't ask for it, you won't get it. And you really need that, because if you continue to eat those things, medication is not a cure. Medication, keeps you from one day to the next day, but it's not a cure. The food, nutrition, and improving your health is a cure. So I want to encourage people to do that. If you don't know what foods to eat or how to prepare a menu, keep watching Fresh, Natural, and Live, and we will help you do that. That's what we're here for.
That's right. Don't wait till you go in the hospital. Great point. Great point. Well, I'm going to see you guys backstage. We'll close out. As I said before, if you give us a thumbs up if you like what you see. Also, subscribe if you hadn't had a chance to do so. And, of course, share this information with any and everybody you think will benefit from this. I think taking care of your health, taking control of your own health is really important, and we want to help you do that as well. So, as always, until next time, keep it fresh, natural, and live.